It was one of the most popular episodes that we actually had last year. I'm talking about heart health and why it's different for women. And now we're going to dive back into that topic because it was so popular. We want to dive a little bit deeper into what is going on when it comes to heart health and women. Thanks for joining us. I'm Marcus Thorpe.
And I'm Lindsey Gordon. Before we get started, give us a rating on Spotify and Apple because that actually helps us reach more listeners. Thank you to those who've already done so. Okay, and also, if you have any questions about anything we talk about today, just drop us a comment and we'll make sure to get those questions answered. Dr. Anne Albers is here today to help us dive into this topic. Thank you so much for being with us, Dr. Albers. We appreciate it. Tell us about your role here at OhioHealth in the heart and vascular space.
Oh, well, thank you for having me, and thank you for coming back to this topic because it is near and dear to my heart. At OhioHealth, I'm a cardiologist, and I work mainly at Riverside, but have done system-wide work, and our goal is to improve the heart health for our community, and I think we have an amazing team doing that. I see patients. I round on the inpatient service at Riverside. From a clinical standpoint, I do the imaging, cardiac imaging, heart testing, and things like that.
I know we've done a lot of heart stories over the year here on the podcast, but for those who maybe are new listeners for us, can you explain kind of why heart really is not a one-size-fits-all when it comes to care, especially when it comes to the difference between men and women? It is different, isn't it?
Sure. Yes. Well, I think, listeners probably can think of the Hollywood heart attack. So when I say Hollywood heart attack, what do you think of? Well, you might think of a man out in the cold going up a stair holding his chest.
Yes.
Because there's like an elephant sitting on his chest. So for whatever reason, that's kind of our collective view of what is a heart issue or a heart attack. In actual presentation, people might have fatigue, they might have sweats, they might have nausea. And I just talked to a patient who had gone to the ER. I think it's probably GERD, but I told her, which is gastroesophageal reflux, or that acid indigestion, I told her my worst worry is that someone will ignore their indigestion and it's their heart and they're having a heart attack. So we're not always wired so that we know, we're not always a Hollywood heart attack. I've had women have the Hollywood heart attack. I've had men present with the Hollywood heart attack. To the question of how do women present, in general, we see that women a lot of times might present and in hindsight would say, gosh, I was fatigued. And I believe me, I take care of a lot of women where they're like, hello, I am
we're
fatigued.
always tired. Yeah.
So
how is this different?
Right.
Yeah.
So it is different though. And in the paper where they identified this as a finding for women, it was a different degree. It was a different overall sense of fatigue. Women might have lightheadedness or dizziness. Certainly fainting is a flag for your heart that there's an issue. But chest pressure, chest heaviness, chest squeezing can be symptoms of heart attack.
Yeah, I will say that in some regard, from just a regular Joe like me, it's scary to think about that I might misconstrued something into, oh, it's fine, and it's really something worse. Now, I have a history of heart disease in my family, so any little twinge or something like that, I pay really close attention to it.
You're aware of it, yeah.
But I could see how people could mistake, oh, it's fine. We do that with our general health anyways. Oh, it's fine. It's nothing. And then it turns out to be cancer or something like that. So we've got to pay attention to our body.
And I think that's the power of screening, and that's the power of knowing, well, how could we look at your risk for heart disease? So being sure that you're staying current with what we know and how we can check.
I think what's tough for women especially is, you mentioned the indigestion, but feeling anxious, right? I mean, those are things that we feel all the time. Fatigue, we feel all the time. There are certain things in life like perimenopause, menopause that ramp those feelings up of exhaustion and anxiety. But sometimes symptoms of a heart attack could also manifest in those ways too, right? And so do you think that's what makes this particularly really challenging for women?
I think definitely. I think is it not? What do I do? All that can be very challenging. And certainly there are life phases for women where we might have a higher risk for heart. I think it's important for women. I always talk to women, so when they say, oh, my numbers are okay. So we have specific risk factors for heart disease, like high cholesterol, high blood pressure, family history. But when people say, oh, my cholesterol was fine, I say, no, I really want you to ask, what's my number? Know your numbers. Know your numbers for blood pressure. We call blood pressure the silent killer because it might be higher as you go through life, or if you have stress, or for different reasons, blood pressure can go up. You might not feel it. So that's definitely a number you have to measure and know your number. I think with knowing your risk and your history for women, that's what I was getting to, and over your lifespan, if you have, we now think of pregnancy as somewhat of a stress test for you, for your adult life. So if someone has high blood pressure with pregnancy, or if they have preeclampsia, which is a condition with higher blood pressure toward the end of pregnancy or even after delivery, that is a marker for cardiovascular risk through their adult life. So
wow.
So I asked my women that. I asked how old they were when they started menstruation, how old they were for menopause, because early menopause can be a risk, or people who have to have premature menopause, we know that is a risk for heart disease.
Wow, I did not know that.
Yep.
I love that we're learning so much more too as we kind of move forward, and even in your world where I feel like, gosh, physicians must know everything. I mean, you're learning every single day and every single year
Right.
too. I think it's really
Right.
cool that that's the way it is. You mentioned stress, and we just had a podcast recently where our guest talked about we have a tendency sometimes to live in bouts of stress where it's just part of what we do, and it's hard. Can you talk about how stress impacts the heart?
Oh, that's a great question. So, we know that when I talk to my patients about this, that you could consider it kind of good stress, bad stress, like how much control do you have over the situation? I think the higher risk scenario is where you are not having a lot of control over your situation. You don't have a good outlet for the stress. So I really like exercise. We know that being out so I like to move my body through space is how I talk to people about physical activity. But the other would be, getting out in nature can help with stress. But yeah, definitely that no control over your situation type stress, which life can throw you a
Absolutely.
lot of curveballs. And yeah, you might not have control over that. But okay, well, how are we managing that? And if you're not actively trying to manage it, either carving out a few minutes or calling and getting help from a counselor or a therapist, there are a lot of opportunities now to get that, or physical activity. There are productive ways to try and manage that stress, but
You can't live in that space all the time.
it's not, no, I would say that's not a great space, not a good plan.
I was just having like a real talk with a mom friend the other day, and we were talking about like in real life, managing stress. How do we do it, And she gave me advice that I keep thinking about, and I want to share it. Like, it's not anything medical, but she said to me, I take what I'm feeling and then counteract it with something that's true, but the opposite.
Mm-hmm.
So like if I feel like I don't have control over something, you can say like, I'm feeling stressed about this, but I'm safe. Like, I'm not going to lose my job over this. I'm not going to, no one's going to lose their life over this. You kind of counteract it with something that's true, and you are safe, you are okay.
Mm-hmm.
And I just keep thinking about that.
Yep.
And I just...
So you identify it, you acknowledge it, and then...
Right.
That's empowering. Because sometimes you might not even feel that you're in that stressed space.
Yeah, if you live there all the time, you're like, oh, this is just my normal, but that normal could be dangerous too.
Yeah.
And that's why I love that we're having these conversations more. It's not, we know that everyone's craving to have these types of conversations, and it's just becoming part of everyday life, and then everyone benefits from it. How easily are symptoms overlooked? Symptoms indicating that, you're heading down the wrong path for your heart health.
Right. I think they can, pretty easily can be overlooked. I think, we had a program, and I know nationwide this is a program focusing on women. In this case, if a woman presents to the ER with any symptoms between the nose and the nose to navel, so belly button to nose, to get an EKG, and that's the electrocardiogram, that's the electrical picture of your heart, and it can detect abnormalities or changes there, because we know that presenting with a heart attack, time is muscle, and it's very important to treat someone expeditiously. So that is an emergency, and we move those people through. And so if you can get that, and the EKG is a lot of times what can start that track. So if you can get that EKG sooner, you can reduce a woman's door to balloon time, meaning the time to try and intervene on an artery problem or blockage. So that's one way. I think talking to women, so the American Heart Association is 20 years ago started with the Go Red for Women to try and increase, because we have kind of 3 areas to improve on, and we're making progress. But number one, are women aware that cardiovascular disease is their leading cause of death? It remains that, despite a lot of progress. So number one, are women aware? Number two, is the medical community aware? So if a woman comes in, do we know to say, okay, these, you might not have the typical presentation, but these things are concerning. So going down that checklist. And then third, just kind of community in general, understanding women are often the caretakers for the family. So I have a lot of patients and actually my women patients where they are, I hear about how they're taking care of their husband, just had surgery, and they are attentive. They take care of them, they're taking care of the children. So we need to have a focus so that women can be able to take care of themselves and empower them. So that all comes back to the American Heart Association's Go Red for Women. And I think there's just been progress.
And I love that you have your pins on. We're just coming.
I do, yep.
It's March now. We just celebrated it in February,
Yep.
but I love that you're wearing them, and it really is a great cause.
Yeah.
What would you say, Dr. Albers, is kind of the one biggest factor that you think people could make changes in their lives right now that would really impact their heart?
So, the most preventable cause of death is smoking. So if you can stop smoking, that's better than most the medicines I could give you.
Yeah.
I think tobacco use, just if you can not ever start or stop once you start. It turns out it's harder for women to quit than men.
Really?
That's one
Yeah.
difference that we've noted. I think as much as you can try and optimize lifestyle, you can't pick your parents, so you kind of get the genetic hand you're dealt, but you can choose. So for example, the stress, kind of how your environment is, what your food choice is. You can't, I have patients who come in, they're like, okay, I'm going to do, the best way to protect my heart, but it has to be sustainable changes. We're habit-forming creatures, so if you can pick one change, or even just do an inventory and say, okay, what opportunity do I have to change? Why am I eating that, maybe a snack later at night? Is it stress? Is it, just kind of do an inventory and look at your behavior, look at how much you're moving your body through space. So if you can get 10 minutes of walking twice a day, that's the guideline recommendation for physical activity. And in the case of exercise, for the most part, more is better, and you get benefit from your cholesterol, which is another big piece of heart risk. It helps blood pressure when you're physically active. It helps stress management when you're phically active. So you asked for one thing, and I gave you like 10.
That's a good doctor right there, though.
Right.
I love that. I'm curious to know, you mentioned, all things to kind of keep your BMI in check, your weight in check as well. What's your take on the season we're in of GLP-1 medications, where, some have said that it's a game changer for people? What's your take on it as it pertains to heart health?
There's excellent data for that whole class for helping protect your heart. the cardiovascular benefits extend beyond weight.
Really?
Yes.
That's so
Yeah.
interesting.
No, they're an impressive new class that, really, I think are excellent for heart health.
That's
Definitely.
awesome. That's good to hear.
Kind of a personal question. So, my dad had 3 heart attacks, and the last one when he was 51, and he died. But heavy smoker, traveled all the time and stressed. For somebody like that, like myself, or somebody else who's had like loss from heart disease, how much do genetics play in, these kind of things? You mentioned that there is some correlation between somebody who's had heart disease in their family and
Right.
me. I'm worried about my kids down the line too, and kind of what it means for them. Can you talk about genetics a little bit?
Right. Well, a little bit is the key thing. So, on levels, there are polygenic risk scores, so there's kind of real detailed information you can go down the genetics path. From my standpoint, in my practice, you're someone where I would check a lipoprotein little a. That is a molecule that's actually, it's 1 in 5 people have an elevated level, and it's a genetic thing. It's not lifestyle related. But if your LP little a is high, this is a molecule, and we detect it with a blood test. But this is sticky, meaning it kind of sticks to platelets, so that can accelerate artery disease. It makes any LDL cholesterol, which is your bad cholesterol, it's better at making plaque.
Yeah.
So, and then the third thing is it just is pro-inflammatory. So we didn't really talk about, another risk we worry about with heart disease are people who have autoimmune diseases, or we know there's inflammation. So lipoprotein little a is a molecule that kind of does all 3. And when it's above a certain level, it's an independent risk factor for cardiovascular disease. So what would we do with that? If I know you have a high lipoprotein little a, I want to get your LDL level as low as we can. So it's a sign that we want to optimize your heart risk wherever we can.
Yeah.
So you look at where you can affect change and do that. And also a medication is far along in development that can reduce that lipoprotein little a by about 80%. It's not yet out, but we at OhioHealth, we had patients participate in the research for that, and it's looking promising that we will have a way to lower the lipoprotein little a directly. But that would be one test to look at. Definitely your cholesterol, looking at blood pressure, like you said, being aware of what would be a heart symptom, what should I look out for.
Yeah. I'm open next Wednesday for our good discussion.
I'm curious to know too, is there a connection between sleep and heart health?
Yes, so sleep can definitely relate to heart health. We look at, from the standpoint of an arrhythmia called atrial fibrillation, patients who present to me with atrial fibrillation or even with high blood pressure or overweight habitus, I like them to get a sleep study, because if you have untreated sleep apnea, I could talk to you all day long about changing your diet, being more physically active, but you are not going to be able to lose the weight until we are able to fix that sleep apnea. Same with the arrhythmia. I had a patient where his atrial fibrillation returned, and it turned out his CPAP machine was not set, like the setting had come off or whatever. It needed to be adjusted. But once we got that tuned in, he was much better managed from a heart standpoint. So yes, it does relate.
This all kind of leads to my next question. It seems like there's a good playbook for all of these things once identified, right? If a patient's advocating for themselves, if they're in tune with their provider and they identify these things, you can act on it. Where are the gaps? And I'm asking more for like the newly discovered things that we're talking about, the perimenopause, the menopause, the hormonal changes for women. In your mind, where are there gaps where we need a better playbook for when, these factors in life are impacting heart health?
So, right, so every cell has a sex, right? So hormones affect us on the cellular level, on the genetic level. We need basic science research to really know what's the benefit for, we just don't know enough about women. It's a strange statement to make, but it's true.
Yeah.
And that's what we need to know more about. So I would hope that women can work with their provider and try and understand what we do know, and I'm hopeful that we will get a plan to be able to do the research that will give us the evidence to know the best way to treat women as they move through menopause or whatever. I mean, symptoms of menopause, there's good support for doing hormone replacement, what type of hormone replacement and how. I cannot at this time say, that hormone replacement will prevent you having heart disease. We just don't have that research. We have a lot of research for a lot of things that can protect your heart health and help you. And so I work with my women to try and do that. And then I do have women where I worry if they have high risk for taking menopause replacement therapy or the MHT or menopause hormone therapy. But, so I that is rare, but I think it is important just to talk with your provider to know what your risk is. So there can be risk for blood clots forming. There can be, people who have risk for stroke or heart attack or who have had that. We take a lot into consideration.
And does the benefit outweigh the risk, right? That's always the question.
Correct.
I mean, I think that's the theme we've uncovered as we've gone into more women's health focused topics, whether it's heart health or whatever, that there's so much that still is not known. And it's sort of validating to hear you say that, right? As someone who's dedicated your life to this and serving women in this space and men. But to hear you say, like, we aren't where we need to be. I don't know. I think that's like great transparency.
Yeah.
And it's only going to help us move it forward.
Right.
I also think it's important to close, as we're kind of running short on time here, but the need for women, men too, but to be self-advocates when they go in to see their physician or their specialist. Too often, I think women have felt dismissed or not heard in certain situations. How can we be better self-advocates when we walk into our doctor's office or have that relationship with our physician? Right.
And you're going against, a physician or a provider who's pressured on time, who, has to get through a lot of things. So I would say, for women, try and be organized. Try and have, if you have a chief concern, stick with that. And don't kind of say the whole, everything. I think I tend toward that too. I talk a lot. But as much as you can narrow down and say, why am I having the jaw pain? Or I think you had said that, do I need to worry about this? And then if you can say when it started, if you can say what makes it worse, if you can say, try and give the details for that. Number one. Number two, know your numbers. It's not enough for a doctor to tell you your numbers are fine. I'd say, well, what are they? And, where do I want them to be? Or why would I want them to be, lower? But just to know the exact numbers, to know blood pressure, things like that. So I think it's a team effort for sure.
It's ownership. It's knowing what you really have to jump into when you walk in the door. So I think that's great. Dr. Albers, this has been a great conversation. We knew you'd be a great guest. We've actually been talking about you for a while to have you on the podcast, so to actually have you here has been great.
Yes.
And I know that we're going to continue these conversations, and I'm sure we'll have you back very soon. So
okay,
thank you.
Sounds good.
Thank you so much.
You're welcome.
If there's anything in this episode that you want to go back and read more in depth, we'll have a transcript at ohiohealth.com/thewellnessconversation. And while you're there, check out the other topics we've had. If you didn't listen to part 1 of this from February of 2024, go back and do that. We think you'll love it.
Yeah, we've had almost 60 episodes now, so there's something for everyone. And we appreciate you helping grow our conversation here on the Wellness Conversation and Ohio Health Podcast. Thanks for joining us. We'll see you next time.